Welcome to Flourishing in Medicine, from Surviving to Thriving. I'm your host, Dr. Mick Krasner, and this podcast is produced by EmPro, a medical professional liability insurance carrier headquartered in New York State. We are committed through a number of peer support offerings to supporting the physicians that we protect.
The way that I conceptualize this, healthcare workers are emotional and intellectual athletes, performing profound feats of intellectual and emotional endurance and performance every time we show up to care for another human being in the worst day of their lives. And in order to reach that state where our healthcare workforce is healthy and thriving, we need to treat ourselves and each other as those intellectual and emotional athletes that we are.
In this deeply reflective conversation, Dr. Stefanie Simmons, emergency medicine physician, national leader in clinician well-being, and the chief medical officer of the Dr. Lorna Breen Heroes Foundation, shares her personal and professional journey into medicine, shaped by a family ethic of service, a historian's eye for systems and change, and a willingness to challenge harmful norms in medical culture. She traces how early experiences of misalignment between medicine's ideals and realities, compounded by unaddressed personal struggles and stigma around mental health, led her to focus on the interpersonal, cultural, and systemic dimensions of healing, especially the wounded healer. Dr. Simmons recounts the tragic story of Dr. Lorna Breen and the Foundation's mission to dismantle structural barriers to mental health care for clinicians, including invasive licensing and credentialing questions, while envisioning a future where healthcare workers are treated as intellectual and emotional athletes. That's right, athletes who deserve training, rest, coaching, and supportive systems. Together, this episode weaves vulnerability, moral clarity, and hope into a compelling vision for a more humane and flourishing medical profession. And now, my conversation with Dr. Stefanie Simmons. So, Stefanie, welcome to Flourishing in Medicine, from Surviving to Thriving. It's just lovely to have you here. Although we haven't known each other very long, I'm really excited to have this conversation.
Thanks, Mick. I'm happy to be here.
So I'd like to start with where I usually begin, with a question about why medicine. Kind of, I guess you can think of it as an origin story. What first stirred in you the idea that caring for others in this way, in the medical way, mattered and was important to you? Anything about, where that came from in your being?
I think I was a little bit of a latecomer. I'm not someone who tells the story of wanting to be a doctor since she was a little girl and using the play stethoscope on her dolls, etc. I actually loved history and loved reading about the forces that shape our world and our geopolitics and the way that populations move. I studied history in college, and I think rattling around in the back of my skull throughout that whole process was sort of family motto of sorts that my father would repeatedly share to us, which is that our duty is to use our talents to make the world a better place. And as I got to the point of thinking about what to do for graduate school, I had a choice to make about what to do. And I had taken the sort of pre-med, pre-dental sort of courses and done my history courses and sort of explored. And I thought that I could probably do the world the most good with my talents by pursuing a career in the sciences, since it seemed to be what I had the most talent at. I applied to PhD programs in epidemiology, genetic counseling programs, and medical schools. And I was going to let fate sort it out. And I didn't get any help through the admissions process. I still had all my options available to me. And so it was really in July of the summer after my senior year that I got the acceptance at my first choice medical school and decided that the fates had spoken, and that that's where I would go. And my ignorance was such, I did not know that residency existed when I accepted my medical school admissions offer.
I'm curious about that maybe family milieu. It sounds like you said it was your father, I believe, who said that. So something about that. And could you just say more about make the world a better place idea and how that, influenced this direction you went into?
Thanks for the question. And this is a little bit of a tender question for me right now since I'm right around the anniversary of my dad's death. So if I seem emotional when I'm talking about this, that's why. My father had three daughters, and he really encouraged education for each of us and learning for its own sake, as well as for being able to be self-sufficient and safe sort of in our lives and in our careers. But there was this real idea that you should choose your work based on how it impacted others and the world around you. And when I think about the careers that we chose, they're service oriented careers. So my sisters are teachers and a dental hygienist. And then I went into medicine. And so there was very much this idea that as you think about where your education leads you and what you do for work, that should serve the purpose of why we're here as people on this earth, which is to make the world around you better.
That's really beautiful. The story itself, how it influenced your sisters and yourself, and also how it lives in you now. And I'm thinking about that early influence that's still guiding you. Can you say anything about what's evolved or even transformed from that influence? I mean, we'll get more into sort of the details of what you do now, but how you see it as a personal evolution for yourself or transformation, if it was even that.
When you are going through the process of medical training and you have this ideal, sort of the Platonic ideal of medical practice, right, as it should be. And then you run into the practice of medicine as it is, which I don't think anyone would claim approaches the Platonic ideal. Maybe there are moments, like transcendent moments, where it does, but we are practicing healing arts in a commercial system. And there's also a process of professionalization in medical school and residency, which, although very important, is also fairly flawed, improving, but fairly flawed. And so as I experienced these flawed systems, I really wanted to be thoughtful about how I could make them better through my lens as a somewhat outsider to medicine and medical culture, and then ultimately as someone who is really interested about what makes the world tick and how movements happen and how change happens, and maybe bringing that way of looking at things to my new profession.
Your work in medicine has woven together your emergency medicine, clinician engagement's been a big part of your journey, leadership, yourself and developing other leaders, um, mentorship. Can you just maybe spend a little time thinking about what are the threads that kind of connected all of those, the clinical work, the engagement as a clinician, leadership development, mentorship?
These are all about the people who are doing the work and the people who are on both sides of that healing relationship. And what I would say is there was one category that was missing from the list, which was the patient physician communication or the patient physician relationship. And so I was very much always drawn to the interpersonal components of medicine, whether that was the relationship of physicians to their patients, physicians to their care teams, the nurses, the techs, the MAs, the clerks that we work alongside, to their learners, or in fact, our relationships with ourselves and what the impact is on individuals as they go through the process of professionalization into medicine and then the practice of medicine. And what I saw was that there were real moments of exceptional humanity in all of those areas and real opportunities for improvement in a lot of those areas as well. Wounded wounded physicians who didn't have help to process the traumas of their experience as trainees and as clinicians caring for patients. Coming from that, really subpar communication at times with patients, abuse of our teams, verbal, physical, emotional abuse of our teams and our learners, and a real opportunity to elevate the way that we treat each other and our patients. And so that became the focus of my early career. I was offered a position as a medical director of quality and safety for my medical group based on some early work that I did after residency. And I had a wonderful CMO that I was working for at the time, and I listened to this offer and I said, "I would love to help you recruit that person, but what I want to do is to look after the patient clinician experience for this group." And to his credit, he heard that and said, "Well, why don't you write the job description for that job and we'll see what we can do." And that really started me down the road of this work, first for that medical group and then the health system that we worked within, and ultimately for a large national medical group of over 26,000 physicians across the country, which really then it prepared me to do the work of leading these efforts in a way where I had leadership but not authority in the settings where the work was happening. And that was what I was doing when the Dr. Lorna Breen Heroes Foundation was formed.
Well, it's really fascinating. I'm thinking about this work you've done early on with patient-physician experience, and it's certainly part of well-being, but you were doing it long before this became, I think, a national conversation, which it has developed into in the last decade, let's say. What you've said a little bit about this, but I'm wondering about looking at it from a lens of what were you seeing that others may have been missing? I know what you talked about what really impacted you, but what could you see maybe with beginner's mind or whatever it was that you were seeing that was just not part of the conversation at that time?
There were some experiences I had, particularly in residency, where as many of us did as part of that professionalization, some really blunt feedback, right? Or maybe even some, I hate to use, just very blunt feedback or an expectation that the time commitment and the level of sacrifice of any personal needs was, you know, not in service of the patients, but in service of achieving like an expected level of commitment to prove that you were there. And so I would push back and challenge respectfully, cogently, in a way that I think people could hear. And having those conversations really was valuable and helped me define where my limits were, how to set them productively, and still frankly do a really great job at the work I was doing, right? And so that that was a process of trying to understand that early on. And so that's where my interest came from is I don't think this is right. And I don't think the fact that I'm having trouble with this is a problem with me.
That's fantastic. And I also think about, I brought up beginner's mind, and one of the things about that quality is to actually ask ourselves what assumptions are we making that may not be true. So you were really in a big way asking, there are assumptions here that I'm not sure, not only not true, but probably not in service of our profession, in service of healthcare in general, and able to ask that respectfully, right? Because you're at the same time worrying about, do you have a future?
That's right. I still need to honor this rotation while I'm pushing back on the expectations of my surgical senior. um, but it really made me interested. And at the end of my residency, I successfully applied for and competed for RWJ fellowship. And it was at the end of residency when I had my second child. I was a two baby resident 21 years ago. Uh, that I developed postpartum depression. And I was really struggling at the end of residency and in my transition in this fellowship. And I did not seek mental health care because I was in the process of applying for my first license, my first credentials outside of training. I had partially, not fully, but partially internalized a lot of the stigma around mental health care in the physician world. And I had a much harder first few years of my career, including dropping out of that fellowship and starting this quality and safety work at the hospital, which ultimately led. Okay, scratch that. Sorry, I have this incredibly insistent, very friendly ginger cat that I'm going to go put outside my office.
I don't know if that needs to be scratched, but we'll honor what you'd like. Yes.
You're welcome to keep her in the podcast if you'd like. She's my little office buddy, and I will say it's one of the perks of working from home
Yeah.
is to have hot and cold running cats. So it was really the offshoot of that feeling of dis- discontinuity between caring so deeply for my own patients and my own colleagues and feeling like I couldn't take care of myself. So I went from training into this first job as opposed to into my fellowship, dove deeply into the operations of the hospital and the group to learn more and to figure out what it was I wanted to do in addition to clinical care, because I always knew there would be something in addition to clinical care, and ended up doing the Keystone Quality and Safety Initiative in Michigan, which was all about safety culture. So it was culture work. It appealed to me and gave me the opportunity to learn about how I could act out those ideals in the clinical setting. And that was what led me to the conversation with my CMO about wanting to do the interpersonal work as opposed to pure quality and safety work. When I started to so part of my work there was to talk to clinicians who were getting bad patient experience scores and coach them. And I'm explicitly not saying coach them how to do patient experience better, because when you actually talk to someone who's having interpersonal difficulties in that sort of motor neuron end plate between the patient and the physician, it is not typically a skill deficit in how to talk to people. There very rarely there's like a big mismatch in culture between where you trained and where you practice, but most of the time it's a wounded healer, and it's somebody who is struggling to meet their own needs and so is unable to fully meet the needs of their patients, even though they're performing the technical aspects of their jobs well.
I'd like to just shift a little bit, Stephanie, for listeners who may not know the full story. If you could just share with us, who was Dr. Breen and what does the foundation hope to change? And then as you do that in the way that you'd like to, if you could just weave in how you got called to that work. I mean, it makes complete sense based on the conversation we've had thus far, but if you can sort of put that together for our listeners, especially.
And everything is clear in retrospect, but I could tell you along the way, none of these zings and zags in my career made total sense. Dr. Lorna Breen was an emergency medicine physician in New York Presbyterian Hospital in Manhattan, in New York. And she was doing exactly what she'd always wanted to do, which was to practice emergency medicine, drive a fast car, and have a black cat. And she was on vacation with her family when the COVID pandemic started. She was called back. She took care of her community and her hospital and her coworkers as the medical director, and was exhausted working 18-hour days, day after day, like so many of us did. Got COVID, like so many of us did. Came back 24 hours after her fever broke, like so many of us did. And was exhausted by the sequelae of her infection and the ongoing needs of her group and her community. She became so exhausted, she was essentially unable to get out of her chair and was evacuated by car from New York City to Virginia, where she was raised. She received inpatient psychiatric treatment and expressed to her family that she was incredibly burdened by the concern that because she had received mental health care, she would be unable to work in New York at her hospital and would lose her leadership position. And ultimately, Lorna died by suicide. 12 hours after her death, the New York Times published an article about her life. And first dozens, then hundreds, and ultimately now thousands of healthcare workers have reached out to Lorna's family and now the foundation to share that Lorna is not alone, that there are a lot of healthcare workers who experience mental health conditions and mental health crises. We have at least the baseline level of mental health needs from the general population, which is 20% of people will have a mental health condition in their lifetime. And there are also specific mental health conditions that we're at increased risk for, including PTSD. Despite that, there are barriers to receiving mental health care that are unique to healthcare workers, including invasive questions about mental health history on our licensing and credentialing, and our malpractice and liability and insurer carrier questions. And when I was making the decision to seek mental health care, my ability to, have malpractice insurance, to work at a hospital, to be licensed, to get disability insurance were huge considerations. And frankly, they were as well for many. So the foundation was born shortly after Lorna died to honor the messages that her family was receiving about the need for a new day for the healthcare workforce. And we work in 3 ways: advocacy, with a federal bill called the Dr. Lorna Breen Healthcare Provider Protection Act that funds well-being programs for hospitals and health systems, and funded the creation of the Impact Wellbeing Guide, which was written in conjunction between the foundation and the CDC. We work in collaboration with national organizations across the country, coming together on a biweekly basis to reduce the silos around this work of professional well-being and to accelerate the pace of change. And with our ambassadors, we have over 500 individual ambassadors who help spread the work of the foundation. And then lastly, we work to accelerate solutions and make sure that the implementation gap between recognized best practices and the experience of healthcare workers in the field is closed. And that's been much of the work around removing those questions of licensing and credentialing applications about past mental health care, substance use disorder care, diagnosis and treatment, and really focusing on current impairment only for healthcare workers. And so we developed a badge. We have maps that track the licensing applications for physicians, nurses, dentists, and pharmacists, as well as the credentialing applications at individual hospitals and health systems. And we've just had the opportunity to badge our first 2 professional liability carriers as well, who have removed these questions. And so that's the work of the foundation. That's the origin of the foundation. And I actually love the story of how I found the foundation. So thank you for asking, Mick. When I was working as the VP for patient and clinician engagement at this large national medical group, I had a team of physician coaches, 12 individuals, many of whom had very extensive leadership positions within the organization. This person I'm going to talk to you about was a regional medical director, and he was getting his MBA. He was also a parent. So busy fellow, a couple of kids, getting his MBA, working as a regional medical director, pulling shifts in the ER, and coaching his fellow physicians when they were experiencing difficulty, right? So he was sitting in his MBA class, and a professor at the Darden School of Business was talking about a case of this foundation he had started. Well, that was Corey Feist, the co-founder of the foundation, Lorna's brother-in-law, who started the foundation with Lorna's sister, Jennifer. And so he said, you should really talk to this guy. He talks about this stuff the way you talk about this stuff. And I cold called him on LinkedIn. I just DM'd him, and he gave me some of his time, and we talked. I asked to be of service. I shared what I was doing in the world, and he put me on his board, and worked with them for several years on the board. Ultimately was seconded to the foundation by my employer for a partial FTE, and then joined as a full-time chief medical officer 2 years ago.
If we were to imagine, like, let's do a little thought experiment, imagining the future of the healthcare workforce and well-being in 5 to 10 years, and things are really have moved in a great way. Mental health stigma is much less. Mental health is seen, seeking mental health care is seen as a strength, as you have advocated and said. If you could just describe two things, what would that world 5 to 10 years from now, maybe it'll be sooner, look like? But also, what did we have to do to get there? What are some of the key steps that you're working on, and that we collectively, as a profession, actually as a country, as a community of people, need to do to get there?
I think the way that I conceptualize this, healthcare workers are emotional and intellectual athletes performing profound feats of intellectual and emotional endurance and performance every time we show up to care for another human being in the worst day of their lives. And in order to reach that state where our healthcare workforce is healthy and thriving, we need to treat ourselves and each other as those intellectual and emotional athletes that we are. So what do you need as an athlete? You need to train appropriately, not just to be able to perform the technical tasks of medicine, but to thrive emotionally and intellectually. You need to rest, because if you don't rest as an athlete, you get injured. And that's what we're seeing with our healthcare workforce, who's not been allowed to rest. They're getting injured intellectually and emotionally. You need a coach, right? Good athletes have a coach. They have somebody who's watching their performance, gives them ways to get better, and is doing that with them. So physicians and other clinicians need coaches to help them reflect and be thinking partners on their performance. And we need to make sure that the systems in place are making the jobs easier, right? So the running shoes, the gear, the track, everything is pulling for the athlete to improve their performance. We need the same thing for healthcare workers. The EHR, the prior auth, the administrative burden, right, need to be stripped away to allow the intellectual and emotional performance of caring for another human being and putting your talents to the best use possible for them. So that's the world I want to see, and that's what I think needs to happen.
You know, it's more than metaphor. The way you described it, to me, it felt like so real. All of those things, our emotional well-being, our intellectual and cognitive well-being, and even our physical well-being, all needs those things. And if we were to design a whole system and an educational approach to bring people into that system in the best way possible, would have to have all those elements. So what a wonderful way to finish. I look forward to more conversations with you, Stefanie, and I want to thank you so much for joining us.
Thank you for holding this space for the conversation.
Thank you very much for listening. We will include a summary of today's podcast and links of and about Dr. Stefanie Simmons in the show notes. I would like to conclude by sharing another practical episode to help you flourish. Dr. Simmons talked about this notion of being athletes, health professionals as professional athletes caring for others. So I'd like you to just take a moment and just notice, as an athlete, there's many levels on which we can care for. So just bringing awareness to the body, the physical level. It's very important that we are in our bodies, aware of our bodies, take care of our bodies as health professionals. Our emotional well-being is central to the care that we deliver. We're often in very highly charged emotional situations. We're exposed to suffering and grief. So perhaps just noticing how you are feeling emotionally in this moment. And perhaps turning toward yourself with just a little bit of care to care for yourself, that support that you need as this emotional athlete as well as physical athlete. And then, of course, our work is very cognitive, so taking a moment to bring awareness to the incredible genius and miraculous qualities of the human mind, your mind, that has led you to embark on a career in medicine. What would it be like to just bring awareness to the thoughts and take care of that part of your body, mind, and emotions, the cognition, taking care of it so that you can serve others and serve yourself, to be fit for our work, for our families and loved ones, for ourselves, and ultimately for this moment. I hope you found this podcast and the simple exercise useful to you, and look forward to having you join us for the next episode of Flourishing in Medicine, from Surviving to Thriving. If you'd like to learn more about EmPro, please visit www.myempro.com. And if you'd like to find out more about EmPro's peer support programs, please visit www.myempro.com/peer-support. If you're a physician or a medical student in need of urgent support, please consider calling the physician support line at 1-888-409-0141. For more information about me and my work, please visit my website at www.mickkrasnermd.com or www.mindfulpracticeinmedicine.com. We'll see you next time.